Here, Jeffery Smith will describe a five-step pathway to go beyond the fragmentation of the different schools of psychotherapy and define how psychotherapy works. So we're now talking about the first step in that five-step process.
Right. And it's a little bit surprising, I think, to realize that most psychotherapies kind of take it for granted that they don't even talk about what it is we're treating. It's surprising that that it's just taken for granted that, okay, we're treating some of the things in the DSM-3, which is a mishmash of syndromes, of mixtures of symptoms. And so I don't think many people have actually sat down to ask, what is it exactly that we're trying to change when we do psychotherapy? What are we really treating? What are the problems we're treating? And so I spent quite a bit of time and effort thinking about that, and have also done a lot of work with some colleagues from the Society for the Exploration of Psychotherapy Integration. And we've sort of together settled on an idea that I think actually covers the basis very well in terms of the huge range of different problems that people bring to psychotherapy and that therapy can help with. So if it's okay with you,
I wanted to maybe give a transition from what we were talking about before, in a sense that we were talking about the concept of living in a world where life forms need to adapt.
Mm-hmm.
And so essentially that thing that therapy deals with is ways in which we don't adapt correctly. And that's how, the simplicity and the beauty of that concept is it's directly related to what it is that living forms do. And the particular form it takes for human beings is we see it in the way the mind functions.
Right, exactly. And so what we came up with was entrenched maladaptive patterns. And let me explain each of those words. I'll start with maladaptive, we just talked about. And interestingly, that maladaptiveness can come from the mists of evolution and things like anxiety that are built into our brains as ways of coping. But it can also go all the way to adaptations from childhood, let's say. And then there's adaptations like addiction is an adaptation that usually develops in adolescence. But they're all adaptations such that there are better ways to approach living. And by talking about it that way as better ways to approach living, we don't have to get into the murky area of what is health and what's not health. It's ultimately up to our clients to decide how they want to live and what way is better than another. So adaptation and maladaptive patterns, well, we don't really work with problems if they're a one-off. If there's something that's going to happen once and never again, that's not a reason for going to see a therapist. And so we're dealing with patterns, and that gets to be important when we start to look at how those patterns are embodied in the mind. And the first word in the definition, entrenched, is one that's quite interesting. If our problems weren't entrenched, then we would have solved them long ago. We wouldn't need to go to a professional therapist. But that too has some interesting implications that we'll get into in section 2, which is what are the common features of these things. So what we kind of agreed on was that EMP, entrenched maladaptive patterns, are really a universal way of describing the things that are results of the calculations of the mind, that this computer comes up with a solution to a problem, and all of those problems that eventually cause us trouble, we can encompass with that one simple definition of entrenched maladaptive patterns.
Yeah, so we're going to talk about how these patterns come about.
Mm-hmm. Yes, so I do want to say, since I'm a psychiatrist and psychiatry is married to the DSM diagnostic manual, so I really want to say that I'm not saying anything different from that, but the EMPs are really subunits of pathology. They're little micro problems, and actually most clients, most people have more than one, and they tend to be organized in layers. So once we can be precise and limited about the things that psychotherapy is really good for, then it starts to give us a much clearer view of how these patterns actually work and what they do and what they have in common.
Yeah, so let's talk about some of the common characteristics of these patterns.
Okay, and that's where once we make a definition of the pathology that psychotherapy treats, it really lets us focus in much more precisely and in a very interesting way into what they have in common. One of the first things that entrenched maladaptive patterns have in common is that they're purposeful. And that we know from evolution. The brain doesn't want to waste much energy. It uses a lot of energy as it is. And so it's not a surprise that the things that come out of our mind are purposeful. And in this case, a broad look at all of the problems that I've seen in my years of practice and heard about says that essentially all of them are adaptations to things that are perceived as threats. Maybe you can argue once in a while that addiction at least starts out as pleasure seeking, but for the most part, the things that really become problems for our clients are problems because the mind perceived them as threats at some point. So they're purposeful in that they're adaptations. They're adaptations in general that are driven by some kind of threat. And they have, we could say, three elements to each one of those. The first element, the technical word is appraisal, is the mind is looking at inputs from the outside and from inside and comes up with the conclusion that there's something dangerous there. And that's called appraisal. So, and how does appraisal work? Well, it's a complicated process, but it involves comparing what's going on now with past experience to quite a large extent. So, and it's also important to think about appraisal as something that has a lot to do with anticipation, that the mind is tremendously focused on catching bad things before they happen rather than after they've already come to be. So that's one part. And then there's the end result of the entrenched maladaptive pattern, which is some kind of behavior or a spontaneous thought or a feeling that pops into our mind or a bodily response. And so those things ultimately are a solution to a problem, a way of adapting to something that the mind has perceived as a threat. Now, I said there were three elements, and maybe the most interesting one is the one that's right in the middle. In a way, I think of it like an hourglass. It starts out complicated, it gets kind of simple in the middle, and then it gets complicated again. The part in the middle appears to be deep limbic emotion. And that's very tricky. Neurophysiologists have a lot of trouble with describing this, because these deep emotions are the things that we have as humans pretty much in common with other mammals. And there are things like pleasure and lust and fear and anger that are pretty common across the board. Neurophysiologists have trouble with it because animals can't tell us what they're feeling. They can't tell us what it feels like to have those deep limbic areas activated. And human beings can't really tell either. And there's a lot of argument amongst neurophysiologists about whether those deep emotions are pretty much the same as what we experience as conscious feelings, or are they something that's really different? We don't know. It also is important that sometimes people have responses to things, to these deep emotions, without any consciousness of them. That's a fairly common phenomenon. The one I like to think of is a narcissistic person who perceives a slight may not even be aware that there's been a slight, but he'll come up with a criticism or a put down without even realizing why that's happening. So that's a phenomenon. But the other side of it is that our conscious feelings are also very complicated, and they involve a lot of additional associations and things that come from our cortex that are added on top of whatever it is that comes from those deep emotions that trigger a maladaptive response. So the thing that's most important about this is that it looks like when it comes to psychotherapy, that one of the most important elements in bringing about any kind of change is those deep emotions have to be reactivated. And the way we know as clinicians that they've been reactivated is affect. If we think about what affect is when you feel something consciously, oh my gosh, I'm scared. And in addition to that, you have some sort of a bodily response. You can feel it in your tummy, your hair stands on end. There's somehow the physical body is engaged in that emotion as well. When we have that combination, which I call affect, that tells us clinicians, when we see tears, when we see agitation of some sort, then we know that something's going on in the limbic system. And that is our clue that that the time is ripe for some sort of change to take place. And we'll get to that in the next section.
So you were describing how these patterns arise as a process of adaptation, and that essentially adaptation to threat, and that the way they manifest is through emotion, affect, where there is a consistency with other mammals, not necessarily conscious and sometimes conscious, and that the key part for clinicians is to be attuned to these affect, because that is where we have the possibility of noticing and intervening.
Exactly. So maybe the one takeaway here that's most important is that maladaptive, entrenched maladaptive patterns are essentially universally triggered by those deep emotions. And so if that's the trigger, and that's a funny thing, neurophysiologists argue about all kinds of things, but one thing they don't seem to argue about is that deep emotion is what triggers our protective responses.
Right. And so, contrary to the old cliche that therapy is about feelings, the feelings or the emotions, in the case the affect, is an entry point. It's not the what we treat, but it's the entry point that shows us where the pattern is arising and how it is triggered.
Yeah, there's a little note here for CBT therapists, because, you know, the tradition of behaviorism was not to ask why, and to kind of ignore that whole area. But I think the place where psychodynamically based therapies and cognitively based therapies intersect is that those automatic thoughts that people have are purposeful. They're ways that the mind tries to influence what we do. At least I would put it that way. And so if I were talking to a CBT therapist, I would say to them, well, you know, if you ask yourself why people have automatic thoughts that you want to correct, there are actually good reasons for it. And the people who seem to know the most about that are the ones who studied psychodynamics for a long time.
Yeah. And so, again, very logically, as we have seen how central affect and especially fear is, we're going to now be talking about dealing with the fear paradigm.
Okay. You know, for a long time, it's been, even Pavlov came up with the observation of extinction, that if you pair a ringing of a bell with an electric shock, then an animal learns to be afraid of the bell. And then if you keep on ringing the bell and not giving any electric shock for a while, then eventually the animal stops reacting to the bell as if it were scary and just takes it as a matter of fact. And that he called extinction. Well, it took a long, long time, all the way to the 21st century, for neurophysiologists to begin to understand why that happens, how it happens. And it turns out, to make a long story short, that there are actually two mechanisms that can cause a change, a lessening of a person's reactivity to something. And so that's really what's fascinating about that, is that for the purposes of psychotherapy and of looking at the common infrastructure that that belongs to every psychotherapy, it boils down, as far as we know at this point, it boils down to two mechanisms, and that's it.
Yeah.
Yeah.
And so let's talk about what they have in common and what's different between them.
Okay. So, and I, well, somewhere in here, I need to say that psychotherapy does quite a few other things, but we're homing in on entrenched maladaptive patterns and how existing patterns can change. And one of the common characteristics that I didn't mention in the previous section about all of those is where are they located? Where are they? Why, if they're patterns, they must be stored someplace. Well, they're stored in memory. And the two mechanisms, one of them has to do with changing memory, and the other one has to do with changing the expression of a threat. So let's talk about the simple one that's maybe better known first. So extinction turns out to be a very distinct, excuse me, a very distinct neurophysiological mechanism. And what happens is that the trigger takes place, that deep limbic emotion gets activated, and then that sets off a response. And when the shock is no longer paired with the bell, or when the situation is no longer dangerous, let's take an example of one of the current treatments for PTSD in the military. They over and over and over again, the therapist is supposed to drag the poor soldier through his terrible experience in wartime, but in a context of safety. because now, you know, there are no longer bullets around. They're no longer, the enemy is no longer there. The war is over. And so it's really okay now. And what the therapist wants is for the safety of the present to override that feeling of danger and to suppress the response, the startle response, or the whatever it is that the soldier is experiencing. What happens is with repeated exposure, the cerebral cortex learns that it's not dangerous, and it sends signals into the limbic area that suppress those limbic neurons and the ones that also represent the response pattern, so that the response is suppressed. But what happens, neurophysiologists have shown that the amygdala, for example, still lights up when there's a loud noise, but the response, the startle response, is suppressed, and the fear, the conscious fear, is suppressed. So in effect, that's a somewhat effective treatment. There's a problem with it, though. Eventually, whether this experiment is done with animals or rats or human beings, it's the same. It wears off, and eventually the old startle response comes back. If it's not reinforced, and so it kind of takes energy to maintain that.
So as we're talking about this mechanism, this big functional mechanism for change, maybe that begs the question of how you got first interested into how people change.
Yes, and it goes back a long ways. In my second year out of residency, I was working with a patient who had been severely traumatized and was dissociative. And it took about 4 years of work for us to finally, for her to become, to recall the horrendous abuse that she had experienced at the hands of her psychotic mother. And when it finally came to light, we had a couple of prolonged sessions, maybe a couple of hours long, where she was re-experiencing that trauma, and at the same time aware that she was in a safe place with me, and that nothing bad was going to happen. So she had that dual consciousness of that the war is over, and at the same time was experiencing those things in a completely, totally vivid way, as if it was happening right then and there. And that was only possible because of dissociation, because dissociation had walled off those experiences for 40 years or something like that. And this was the first time that she had ever accessed that memory. And so as that happened, you know, we went through it, and I asked her about different aspects of it. And we had a second session where we again looked at other things like, you know, was there anger? Did she blame herself for it? And all of the other facets of that experience. And at the end of those sessions, she felt worn out. So did I. But those memories were just a dull ache. They were no longer threatening the way they had been before. And to me, this was, you know, having seen that therapy has a tendency to go on and take a long time, to see something that was healed essentially in a few hours and was done with. And the remarkable thing was that those memories were never threatening again. That was it. It was done.
And so that's maybe a great way to explain how there is a very important difference versus the extinction. It's not just a question of repetition, but it's something that happened that engaged the memory in a different way.
Right.
And, you know, maybe you want to describe a little bit this process.
Right. So a few years ago, when I read about the work of Nader and some other neurophysiologists that had clarified the how this actually happens, I was blown away. And there was still some controversy in the field about whether this process, which is called memory reconsolidation, whether that actually is operative in psychotherapy. I don't think it always is, but at least I had that experience where there's no other plausible explanation of what happened. It wasn't the extinction mechanism that requires repeated experiences, because we didn't have to repeat them. And it was a very rapid and very complete process right then. So what neurophysiologists have clarified about memory reconsolidation is that when a memory, such as a traumatic circumstance, is brought back to consciousness, is reactivated, and at the same time, when there's some other information that contradicts the original one, in this case, the contradiction is the war is over, it's okay now. When there's something contradictory, that triggers a state where the memory neural networks become volatile, become subject to change. And they can either go back the way they originally were before the thing happened in the first place, which can be done with chemicals, or in therapy, it can be, the memory can be rewritten according to the new information that, yes, this happened, but it's over with. It's not something that you have to be afraid of or have dread for right now.
Right.
And
So the difference is that in the other one,
Mhm.
in some way in the therapy room, the war was over, but you did not have that same degree of engagement of the
Exactly.
client. And
Mhm.
so we're talked before about how the mind is essentially a predictive organism, has
Mhm.
that predictive function, and
Mhm.
engaging it gets it to work and change it, the way it interacts with the world.
Exactly. So something that was a threat before is no longer a threat. And along the way, it's interesting to realize that if we ask ourselves, how does the mind know that something is a threat? Is there a label? Does a word get attached to a circumstance that this is dangerous? No. The thing that tells the human mind that something is threatening is those limbic emotions. When those emotions get attached to a set of circumstances, then that's what the mind knows is dangerous. And so if we cut the connection between the limbic emotions and then the circumstances that were appraised, then it's no longer going to be threatening.
Right.
And that's exactly what happens. How does it happen? It has to do with the regulation of synapses that make a group of neurons fire together, called neural networks. And that's complicated stuff we don't really need to get into. But the amazing thing is that to a greater or lesser degree, the synapses that hold that information are forever changed. And that change is what makes it possible in psychotherapy for this kind of remarkable thing to happen, where something that was a cause of all kinds of dread and maladaptive mechanisms for avoidance of that dread to not be a problem anymore.
Yeah. So we're talking in terms of adaptation, we're talking in terms of learning, but the difference is this is not just a cognitive problem, because the driver here is the coupling between the experience, the circumstances, and the limbic system and the deep emotions of the visceral emotions. So
Exactly.
yeah. So now, how do we actually make a change? And is there a difference between the case of extinction or reconsolidation?
Okay. Well, here's the piece where it really starts to get interesting. What turns out is that the conditions necessary for these two change processes, and these are the only ones that are known to be able to change established maladaptive patterns. So the conditions that are required for these two change mechanisms to take place turn out to be the same. And that is, there needs to be activation of the limbic emotions attached to the original circumstances that were causing trouble. And simultaneously, there needs to be, I'll use the word exposure. I'm not talking about exposure therapy. I'm talking about the client needs to be exposed to surprising new information that collides with the old perception. And neurophysiologists say that what's happened is there's been a prediction error, that the mind is very good at detecting when it expects something to happen and something different happens. And so it's that combination, and that's going to turn out to be really, really interesting when we start to look at how different sorts of therapies bring about those conditions. But again, those two conditions then would be, from a clinician standpoint, would be that we see the person in touch with, in an affective way, in touch with their maladaptive pattern, and at the same time aware, conscious of information that goes against the perceptions that led to the maladaptive pattern. So it might be in the context, it might be just the warmth and safety of the therapeutic relationship that contradicts, or it might be something more cognitive. It might be an idea that contradicts something.
Or an experience.
Yeah, I'll give you an interesting example. That the same patient that I described before had, over the years, had blamed herself for her mother's troubles, for her mother's bad behavior. And one day her father showed up, who had disappeared for many, many decades, and he suddenly came back into her life and told her that her mother had been hospitalized before my client was born. And in that moment, I wasn't there, but I was told about it. In that moment, she flew into an uncontrollable rage. And what that said to me was that here was a piece of cognitive information that required some logic to figure out, well, if mom had been hospitalized before I was born, then I can't have been to blame for her psychosis. And that logic had to take place up in the cortex someplace, but it had an immediate effect of undoing all of that self-blame and that had been holding her rage in. So it's an example of how words can actually be very, very powerful. It's not, so therapy is not just about feelings, it's also about words and ideas and meaning. It's really when the two of them kind of come together. There is one interesting piece of research, and to my knowledge, not too much other than that, that says that if a situation is recalled once or twice or even 3 times, then memory reconsolidation takes place. If it's repeated more than that, then the brain begins to operate based on extinction. It begins to be that cortical inhibition of the response instead of erasing the response. So it may be that that's what makes the main difference between extinction and memory reconsolidation. I think both of them operate at different times in psychotherapy, but they are distinct neurological mechanisms. They have the same conditions that bring them about, and they have the same result, that the person no longer is reacting the way they used to.
So we talked about the steps, and maybe it would be useful to put this in context of how this approach fits with other modes of psychotherapy.
Right. So, what we come to looking at these mechanisms of change is that the sort of the essence of it is having this juxtaposition of activation and awareness of the old way of experiencing things and responding to them, and at the same time having a more, call it mature, but a more accurate adult perspective that clashes, that collides with the more primitive, way of understanding things. And when we then try to map that, it doesn't really require trying. It maps very, very naturally to the techniques that are woven into every therapy. There's some where it's more obvious and clear. One of those is Alexander and French's idea of the corrective emotional experience, where they described how a client will have an expectation within the therapeutic relationship, expect the therapist, oh my gosh, you're going to judge me for this or something like that. And then the therapist doesn't do that. The therapist has a completely different response. And what Alexander and French said is that's really kind of the essential core experience that results in change in psychotherapy. And
So what's happening with this approach, with this model, is that instead of thinking of it as corrective emotional, that it's correcting the emotion, that literally is that you're correcting the understanding of the experience, the perception, the relation with the experience.
Well, right. It's all three elements. It's the appraisal of the circumstances, the way the person understands the circumstances, the emotion that sort of encapsulates that as a concern or a threat, and the response to it. And they all kind of go together as a unit. That's what we really mean by entrenched maladaptive pattern. It's that whole three elements all together. But the way that they get modified is right at the core, where the circumstances meet the emotion is where the correction happens. So that's one example of how this model maps onto what's known from other theories in psychotherapy, but it's not the only one. Another place where the mapping is very natural is with mindfulness-based therapies, because mindfulness, again, is this experience where you have the experiencing self that's right in the middle of something that we're reacting to, and then mindfulness implies a larger perspective that's brought in at the same time that reframes what's going on. And so mindfulness is another way of describing the same juxtaposition of the old response and the new response colliding together. And then, I think we can think of some other things like insight. What is insight? Well, insight is bringing in an alternative perspective. And we kind of know that the timing of insight is important. Well, why is it important? Because it needs to be timed in juxtaposition to the experience. And that's what makes a successful interpretation. Exposure therapy is another kind of clear example from psychotherapy, where a person is experiencing something traumatic, and then simultaneously they're doing that within a context of safety and a larger awareness that just comes from sitting there with a therapist, where you both know that the war is over, and you're no longer, those loud noises are no longer explosives and dangerous.
Right. And what's interesting in this case is to see a difference that is very clear between these, where there is a reworking of it, versus simply extinction. This is not the absence of danger, but this is a re-experiencing in the presence of safety.
Right. Now, it may be that, like, the protocols for exposure therapy in the military, and I think as it's classically practiced, involve over and over repetitions of the trauma. And what we know is that if there's any condition that's going to bias towards extinction, towards that cortical inhibition of the response, which is temporary, as opposed to this memory reconsolidation, which is permanent, it would be the way exposure therapy is practiced. So I think in reality, probably the exposure therapy protocols produces some of both, some extinction and some memory reconsolidation. Even cognitive behavioral therapy produces the same kind of juxtaposition, because if you're changing behavior and that behavior has been blocking a certain emotional experience, then that emotional experience is going to well up and the context will be different. And so there's opportunities there again for the same kind of juxtaposition. And similarly, if you're trying to change maladaptive thoughts, there's again, it's activating when you try to change your thinking. You're bringing the old way of thinking and a new way of thinking into the same context. And so again, you have the same kind of duality.
Here it works, even though the theory of cognitive behavioral therapy does not necessarily encompass that understanding.
Right. And actually that's been one of the areas of debate, I think, in the CBT field is, does it really work the way we think it works?
Right.
So I think that in the end, we're going to see that this kind of model has quite a bit to contribute to that conversation. So, you know, I'm sure there, in pretty much any therapy you might look at, there's going to be, it's going to fit fairly well with this model. There is now, I'm not sure if I mentioned it before, that this is not all that therapists do.
Yes,
and it's not
talk
all
about that.
therapists.
Yes, that is,
Yeah. Yeah. So, okay, I didn't want to leave that out. So yes, that's a glimpse of how this model maps onto existing theories. And in doing that, it makes a kind of a Rosetta Stone, because it gives a common way of understanding what's going on in a lot of different therapies that have each one their own parochial theory.
Yeah, so we have been talking about the ways in which this approach helps make sense of what happens in therapy, pretty much regardless of what the theoretical orientation is.
Right, or in fact that it really kind of clarifies existing theories and gives a depth and precision, I think, to the way we understand. You know, for example, when in those therapies that emphasize insight, the idea is that, well, insight is the curative agent, and that's not really quite accurate. That's only one element of what makes it work. And so to be able to conceptualize that you need activation of the original emotions and the original kind of threatening situation at the same time as you have insight, that gives us a fuller picture. And so to that extent, I think it actually adds something to some of the traditional theories. And I think it's valuable in that way, as well as providing this Rosetta Stone sort of effect where we have a common model that's compatible with all of the various theories, you know, most of which are really elaborated in the terms of their own tradition. And so they're very limited kinds of theories, except for the people who have embraced that particular therapy.
Yeah.